So today we are going to be talking about leukemia and lymphoma. So what is leukemia? Leukemia is essentially cancer of the white blood cells. If I get my stuff open. Essentially, the white blood cells, they're not functioning the way that we want them to. And the white blood cells are our major part of our immune system. It's what helps us fight things off. Typically, with leukemia, it's an overabundance of immature white blood cells. So essentially, they're not fully developed to work the way that we need them to. The mature white blood cells are called SEGs, S-E-G-S, and then the immature white blood cells are called bands. So sometimes looking at blood work, you will see it say bands percentage, and that's the percentage of the immature blood cells, white blood cells. When your band number is increased or high, that means that your body is creating more white blood cells to fight off an infection, but they're not as effective. So even though you have a larger abundance of them, they're not going to work the way that we want them to. There are a couple different types of leukemia. Acute lymphocytic, chronic lymphocytic. For our intents and purposes, we're going to treat leukemia as just one. So we are going to just talk about like treatments for leukemia, diagnosis of leukemia, not the different types of leukemia. They are types of leukemia, but you don't have to know what differentiates them or how to tell them apart. So different risks of leukemia. One of the big ones that I have seen a lot are previous cancer treatments. I've seen a lot of patients that get treated for breast cancer and end up with a leukemia afterwards. That just has to do with your bone marrow being affected by the chemotherapy treatment and it causing an alteration to your DNA. Higher prevalence in men, smoking. If nothing else, notice that smoking is one of the number one risk factors for almost every single type of cancer. Leukemia is a blood cancer, so you wouldn't think that smoking would have an impact on it, but it does. Chemical exposure, that's more like exposure to pesticides, prolonged exposure to pesticides. The high dose ionizing radiation, that is like from like nuclear reactors or like nuclear meltdowns, things like that. One of the other things it said was atomic blasts. I don't know that any of us have been exposed to that, but other countries, anybody that comes over here, or if you go over to a different country where they have had atomic incidents, there may be a higher prevalence of leukemia there. Genetic disorders, that's along the line of chromosomal deficits. So like Down syndrome patients are a lot higher risk of developing leukemia. And then children with immunodeficiency syndromes. The hypogammaglobulinemia is a disorder caused by low immunoglobulins or antibody levels. So essentially your immune system can't fight off as big of a response. The different symptoms for leukemia. Big one is bone pain. A lot of patients complain of bone pain. That's because your blood cells come from your bones. And when there is an overabundance of white blood cells, it's because your bone marrow is pumping out too many white blood cells. So that can sometimes cause you to be a little bit achy. Joint swelling, weight loss, again, that's a common one for all types of cancers. Fever. you'll see that it has anemia, thrombocytopenia, and neutropenia. That's because this is a blood cancer, and the blood will then be most affected by it. So what type of diagnostic tests do we use to diagnose leukemia? CBC, typically when you get your routine blood work every year, if leukemia is developing, we'll see a change in your CBC. The white blood cells will be increased, decreased, or normal, but it's the bands that typically we look at. For CLL and CML, which are two different types of leukemia, I typically see a very high white blood cell count, like extremely high. And that's because of all the immature white blood cells causing that number to read elevated on a CBC. Typically, because your white blood cells are so high, your other blood cells will be decreased because there's just not enough room and your bone marrow is too focused on making the white blood cells. Occasionally, we'll look at coagulation studies, but typically what we use most times to diagnose any disorder of the blood or of the bone marrow is by a bone marrow biopsy. And when we do that, it'll show a large amount of bands, which again are those immature white blood cells. So, diagnostic test for leukemia, bone marrow biopsy. Bone marrow biopsies, if you've ever had one or seen them done, bless your soul. These are done by providers or advanced practitioners, not nurses, but it is essentially the aspiration of bone marrow, or sometimes a little bit of bone tissue, depending on what they need. It can show whether your bone marrow is healthy or making normal amounts of blood cells, or in the case of leukemia, overactive blood cell creation. Typically, the patient is awake and they're just using localized anesthetic to numb the area. The bone marrow has a fluid portion and then a more solid portion. In the bone marrow aspiration, a needle is used to withdraw a sample of the fluid, and sometimes they will also get the solid, foamy portion of the bone as well. Typically always going to be the back of the pelvis, because that's one of your biggest bones. For leukemia, the leukemia treatments that we are going to look at are listed here. Radiation is not used for leukemia. I just want to point that out. Chemotherapy is typically split into a couple of different parts. 7-3 is a regimen that I'll talk about then, but the different parts typically to treat leukemia is going to be the induction chemo. Patients that are diagnosed with leukemia will get induction chemo because we want to essentially obliterate their cancer cells as much as humanly possible and get the patient into remission. And then after that, we will typically do a consolidation type of chemotherapy, which would be like maintenance chemotherapy to keep the patient in remission. If they're following the patients and they see a spike in their like white blood cells, then they'll give them consolidation chemo to try and keep it from full-blown coming back. The way regimens work is there is normally a typical amount that you would get. Like they would get 6 cycles of a regimen. They would get 3 cycles of 7-3, and then we would check them, see how their blood cells are responding. So long as there's a good response, we'd give them the rest of the cycles. And then after that, we would just monitor. In younger patients, acute myeloid leukemia, or AML, is more prominent, as well as patients under 60. And then that's when we would use the 7-3 regimen. 7-3 is 7 days of cytarabine chemotherapy and 3 days of idarubicin, which is a cousin chemotherapy of doxorubicin. Patients that are getting this will be hospitalized, probably for close to a month, because it's a very strong chemotherapy agent and it's used to essentially obliterate their white blood cells. So other types of treatment, because we are trying to destroy all the bad white blood cells, sometimes we will give these patients colony stimulating factors, so filgrastim or erythropoietin, to try and help increase those blood levels again because we just knocked them all down. And then typically younger patients are a candidate for a bone marrow transplant. It's not always the treatment of choice, but it can be. Nursing interventions for you guys. So the number one thing that you guys as nurses should monitor for is infection. These patients, because they have no white blood cells or immature white blood cells, are not able to fight off infections the way that a healthy person would be able to. Infection, and then monitor for bleeding, because we are affecting all of the blood cells. So even though leukemia is typically the white blood cells, all of the blood cells do get affected. So we also want to monitor for bleeding. With leukemia patients, infection and bleeding are the main two causes of death. Number one being infection. Leukemia patients get an infection, they can't fight it off, and then it results in their death. Definitely support the patient and the family. Educate the patient that depending what kind of treatment they're going to be getting, they might be hospitalized. Induction chemo, and then depending on what kind of chemo they get, they can sometimes be hospitalized for 3 to 4 weeks, which can definitely be a strain on family, on the patient. So what is lymphoma? So lymphoma, when we talk about leukemia and lymphoma, they typically go hand in hand because both of them are either considered a blood cancer, as you've heard me say, or a liquid cancer, because typically these ones don't form as a tumor. With that being said, some patients get diagnosed with lymphoma when they see an enlarged area, but that's really just inflammation and cancer cells in a lymph node or a lymph grouping of cells. The definition for lymphoma is cancer of the lymphocytes and lymph nodes. Lymph nodes produce antibodies and fight infections. So taking us back to biology again, remember that we have B lymphocytes, which make antibodies, and then we have T lymphocytes that we use to fight infection. So Hodgkin's lymphoma, as we just heard briefly, is typically caused by some type of exposure to a virus or different chemicals. With Hodgkin's lymphoma, when they take a sample of their bone marrow biopsy, it will be positive for these Reed-Sternberg cells, which is this picture right here. Basically, it's a cell with 2 nuclei, so it almost looks like, they say owl eyes, but meh. So to be diagnosed with Hodgkin's, you will have this type of cell. This one spreads throughout the lymph system because it is a lymphoma. This one's typically very treatable, and it usually will begin with like your B lymphocytes. Typically, it doesn't spread. However, in late stages or if not treated quickly, it can spread to other parts of the body. And just remember, those B lymphocytes, again, are the ones that make antibodies. And then we are going to look at non-Hodgkin's lymphoma. So non-Hodgkin's lymphoma has a couple different causes, has viruses as well as chemicals, but it also has any damage to the DNA, any autoimmune disorders, and pesticides. Non-Hodgkin's does not have those Reed-Sternberger cells. I would explain that the Hodgkin's typically will be in one localized area, or one group of lymph nodes, where non-Hodgkin's typically will affect different lymph nodes in your body, not just one group of them. Lymphadenopathy. So what that is how I was explaining how a lot of times lymphoma is diagnosed by a lot of times I've seen it diagnosed by a growth on the neck, because you have a bunch of lymph nodes throughout your neck, and all of a sudden you'll look in the mirror one day and say, that looks a little bit swollen. Essentially what it is it's not painful, but it's swelling of those lymph nodes, and that's because of lymphoma in there rapidly dividing. It doesn't necessarily cause a mass, but it will feel like a mass because it'll be a grouping of liquid. Risk factors for lymphomas. So young adults, aged 20s-ish, and then again after 55 are at a higher risk for Hodgkin's. And then anybody above 60 is typically at a higher risk for non-Hodgkin's. Happens more in males than females, but really it happens in both. History, if you have a family history of lymphoma, you're going to be at a higher risk. If you have a weakened immune system, and then obesity, specifically for non-Hodgkin's lymphoma, will put you at a higher risk. Symptoms of lymphoma. So this image has a lot of different terms and things on it. Specifically, the ones that I look at are enlarged lymph nodes for both Hodgkin's and non-Hodgkin's. You will have that area of growth that causes concern and causes the patient to come to the ER or come to the doctor's office. The B symptoms, like were discussed in that video, the B symptoms that were explained in that video are fever, night sweats, weight loss. A lot of times these patients will have fatigue or frequent infections, and then itching. Pruritus is another big one for these patients. Sometimes there'll be more symptoms than that, depending on where the lymph nodes are that are affected. Like if they're in the chest or around the chest, then sometimes the patient will complain of chest pain. They'll have a cough, trouble breathing, because of that pressure in on the chest. B symptoms are fever, weight loss, and night sweats. So B symptoms, that'll be more of a Hodgkin's. It can be with both, but it's typically with Hodgkin's. And essentially, it's just a grouping of symptoms because of the effect on the B lymphocytes. Diagnostic tests. So diagnostic tests for lymphomas are going to be a CT scan used to identify the size, shape, amount of the tumor burden or the tumor load. And then we'll use sometimes a chest x-ray to confirm the diagnosis, to see that there is some type of fluid accumulation. And then typically they will do a lymph node biopsy. That's either where they just go in and they suck some fluid out and look underneath a microscope at it, or they will actually take a lymph node and then do it that way and look at the cells inside the lymph node. Again, Hodgkin's is going to be that Reed-Sternberg cell, and non-Hodgkin's does not have Reed-Sternberg cells. Sometimes they'll use PET scans and bone scans to see for any metastasis. I personally like patients that get PET scans because it can show you what areas of the body the lymph system is affected. And that's when a lot of times, I don't know that anybody ever says it to a patient, but I know between nurses will say they lit up like a Christmas tree, as in like there are spots all over the body because your lymph system is everywhere that light up. And then they'll get another PET scan after treatment or halfway through, and essentially it's gone. There may be like 3 spots that light up versus the 20 originally. The Ann Arbor staging system, this is for your information. This is not on the exam. It's just another type of staging that is used specifically for lymphoma. So the Ann Arbor staging classification for Hodgkin's disease defines, or non-Hodgkin's, depending on what you want to look at, defines stage 1 as involvement of a singular nodule region. So that's going to be like one grouping of lymph nodes. Stage 2 is typically going to be more than one grouping and typically above the diaphragm. Stage 3 is involvement on both sides of the diaphragm. So as we can see in this picture, the little red dots are the lymph nodes that are affected. There's some down in the groin and there's some up near your clavicle. And then stage 4 is going to be diffuse disease. So that's going to be above, below, to other organs, essentially metastasis. Treatment for lymphoma. So treatment for lymphoma depends on what kind of lymphoma you have. Typically, we will do chemotherapy. Occasionally, radiation is used for lymphoma. More along the lines of bulky tumors, which means that they have a lot of disease in their body. They have a high disease tumor burden. With the chemotherapy, the most combinations that are used to treat Hodgkin's lymphoma, which abbreviated as HL, is going to be ABVD regimen. So, typically, this chemo is given every 2 weeks for 2 to 8 months. So it's a long time that these patients typically will get this one. Again, chemotherapy will always depend on the staging and the staging and the area of which the tumor cells are, cancer cells are. ABVD stands for doxorubicin, also known as adriamycin, bleomycin, vinblastine, and dacarbazine. So the way that it's abbreviated is the first letter of each one. Non-Hodgkin's lymphoma typically will be treated with CHOP. This chemotherapy is, again, most common treatment, and it's made up of cyclophosphamide, doxorubicin, vincristine, and prednisone, which is not a chemotherapy, but it's a support drug. For the immunotherapy, typically they'll use monoclonal antibodies, MABs. Specifically, the one that I see used a lot is rituximab. When it's added to CHOP, they call it R-CHOP for rituximab and everything else. Rituximab is an antibody that they develop in a lab, and it specifically targets CD20 cancer cells. So, to recap, we went over leukemia and lymphoma. Leukemia is cancer of the blood cells, typically starts in the bone marrow and will then travel through the bloodstream, where lymphoma is a cancer of the lymphatic system that will originate in the lymph nodes. I just want to touch on bone marrow transplants because this is in the NCLEX, and I cannot promise it's not going to be on your next exam, but if it is, it should be like 1 or 2 questions, not even. So, essentially what a bone marrow transplant is they are going to remove your own stem, or depending on what it is, they remove stem cells from yourself or from a donor. The patient will get chemotherapy that will completely destroy the bone marrow, and then the patient will receive the bone marrow stem cells back into their body. So typically, there's a high-dose chemotherapy that's given to kill the bone marrow. Before that, if it is going to be an autologous or an auto transplant, they will give the patient filgrastim to stimulate the blood cell growth so that there's going to be more cells that they can collect from the patient. Filgrastim.
Is given to the donor or the patient?
The patient, when it's the patient's own cells.
Oh.
So when the patient is the donor. With auto stem cells, there's a very high prevalence of recurrence because the body and the cancer cells remember those cells. But sometimes there's less side effects. Not sometimes, always there are less side effects with auto stem cells, auto stem cell transplants. So they will try that one first, especially if their cancer is not as aggressive. So they hopes to get away with an auto and not have as many side effects. But yeah. And a lot of times they'll try the auto first to see if it takes. And if it doesn't, then they'll go to an allo transplant if the patient decides to. So here we saw this picture previously. Again, it just kind of goes over the difference between an allo and an auto transplant. Again, the auto is going to be your cells. It's going to be the patient's cells that they take out, they cleanse, and then they will give back to the patient. And then an allogenic is somebody else's cells, somebody that donates them, and the patient matches with them, and then they, again, still go through the chemo to obliterate the cancer cells, and then get those stem cells back, bone marrow cells. That term is interchangeable, I'm sorry. Complications of bone marrow transplant. Pancytopenia, which is going to be low blood cell counts for everything, because we are destroying all of the blood cells. We're destroying the bone marrow. Failure of stem cells to grow, which essentially means that the body doesn't take the bone marrow, the stem cells, and then they have to repeat sooner than later another transplant. And then the biggest side effect or complication of bone marrow transplants is going to be the GVHD, graft versus host disease. Essentially, the body attacks the new donated cells. It can happen in your skin. You can have GVHD of the liver, of the GI tract. Typically, it'll appear weeks after treatment, if not sooner. Chronic GVHD can also occur years after treatment, and or for continuous years after treatment. A lot of times, GVHD is diagnosed by a biopsy of that area. So then these are just different pictures of GVHD. The one of the skin essentially is the entire body will end up looking like that. And the patient will continuously be lathered in creams, different types of steroid creams, anti-rejection creams, anything that we can really help. These patients, especially with the skin, they develop a lot of infections because their skin is open in a bunch of different areas. It's typically very painful and very sad. So, to try and help prepare you guys for the next exam, which you guys are not going to want to do right now, but I'm still going to show them anyways, I have added some review questions at the end of my lectures to try and help explain thinking of testing questions. So, this question says, the client asked the nurse, they say I have cancer. How can they tell if I have Hodgkin's disease from a biopsy? The nurse's answer is based on which specific rationale? Any thoughts? Do you want me to go down the explanation? Go ahead. So the answer is going to be number 4. The healthcare provider takes a small piece out of the tumor and looks at the cells. So, looking at this question, how I typically look at questions is I will not look at any of the other answers, and I go down one by one to see if they answer the question. So for this one, when we're looking at the number 1, biopsies are nuclear medicine scans that can detect cancer. Why did we not pick this one? Because that's not what it is. Biopsies are not nuclear scans. They are actually the removal of tissue. So that means number 1 is wrong because it's actually wrong. Number 2, a biopsy is a laboratory test that detects cancer cells. What about this one? What made you not want to pick this one?
Because it doesn't tell you specifically what type.
My thought process on this one is that it's not, a biopsy isn't really a laboratory test. It is a procedure. And when it says laboratory test, that makes you think that a lab technician can review it, where a biopsy is sent to a pathologist or sent to a physician to actually look at the cells. A lab tech doesn't have the scope to do that. So this is working outside of that scope of practice. Number 3, it determines which kind of cancer the client has. So what are your thoughts on this one? My explanation for not picking number 3 is it doesn't answer the question. The patient is asking, how can they tell if I have Hodgkin's disease? And it's saying that the biopsy tells you what kind of cancer you have. But you're not explaining to the patient, like, how. Like, the patient knows a biopsy is going to tell them what kind, but the patient's asking, how do we know it's not Hodgkin's specifically? So that's when I would pick number 4. It's right because a biopsy does remove a small piece of the tumor to look at the cells. It's looked at under a microscope. Specifically, Hodgkin's lymphoma has the Reed-Sternberg cells, so we could go into depth with that. I think I would like this question better if it said that, because then that would almost be like an indicator. But it would be examining those cells to see how we would know if the patient has Hodgkin's lymphoma or not.